Hello, everyone. This is Dave Iverson. I'm contributing editor at the Michael J. Fox Foundation for Parkinson's Research, along with a founding member of the Fox Foundation's Patient Council. And I want to welcome everyone to today's webinar, which is More Peaks, Fewer Valleys with Levodopa, Evening Out the On-Off Cycle. It's part of our Third Thursday webinar series. On the third Thursday of every month, you can join us for one of these webinars when we take up topics that are currently of key interest both to the patient community and to the research community as well. They're always on the third Thursday at 12 Eastern, 9 Pacific. Before we get started, just a couple of other quick notes. We really welcome your participation in this conversation, and you'll see on the computer screen a little Q&A box. So if you have a particular question you'd like us to address, go ahead and send us those questions. We'll try to get to as many as we can, starting in about a half an hour or so. So do send us your questions. And also I want to make sure that we thank AstraZeneca, which is our sponsor for this webinar series. So thanks to them for making this series possible. Let me introduce who's going to be joining us on the webinar today. First of all, we have Dick Fitzgerald, who has been diagnosed with Parkinson's in 2007. Also joining us will be Dr. Lama Shaheen. She is a neurologist and instructor at the University of Pennsylvania, and Dr. Todd Scher, who is the CEO of the Michael J. Fox Foundation, and we'll be hearing from all of them in just a moment. But before we do that, we also want to go through who it is that, what it is that we're going to be covering on today's panel. We're going to talk some about what on-off episodes actually are, why they happen, what are the kinds of things that you should be keeping track of to go ahead and share with your neurologist, how neurologists manage those episodes, and what new therapies are in development that can help us deal with on-off episodes in the future. So that's what we're going to be covering. And we want to start with just a quick definition of what on-off episodes actually are. Starts really with the idea that Parkinson's medications can lose their efficacy, meaning that their effect wears off sooner over time. Doesn't mean the medication no longer works. It just means it doesn't always work as well or for as long-lasting a time. And if you take too much, it can prompt dyskinesia. So on is when the medication is working, off is when the medication has worn off, and obviously the ideal situation is when we have as much on time as possible. So let's get started with our panel, and we're going to begin first with Dick Fitzgerald, who is 67 years old, lives in Nashville, Tennessee. Dick was diagnosed with Parkinson's in 2007 at the age of 61. Is on Sinemet as well as some other medications. Initially, his on time would last for about 4 hours, but it started to diminish. Now that on time is not quite as long, and symptoms reappear more quickly. And when that happens, Dick's left hand begins to tremor more. So, Dick Fitzgerald, thank you very much for being part of our conversation today.
Well, thank you for having me, Dave. I appreciate being a part of the program.
So we see on the slide there, we have this great picture of you mid-swing, and we picked that because in a conversation that you and I had earlier, one of the times when you really notice that you're off is the way in which it affects your golf swing. So what starts to happen when you're off? Because golf is something you're an avid golfer, good golfer, and it's problematic. Describe to us what happens when you're off and how that affects that golf swing.
Well, the medication that I'm taking was initially effective for about a 4-hour period. And of course, on the golf course, I oftentimes get involved to the point where I sometimes exceed the 4-hour time period that I know that I can expect the medication to be effective. So my first problem has been making sure that I keep track of the time, and I quickly get reminded, however, that I have passed that time, certainly, when I'm experiencing the symptoms of my Parkinson's, and that being, as you mentioned, tremors begin to appear and surface when I'm trying to grip with my left hand, and I can't get a good solid firm grip that is not fraught with some tremorous sensation in that hand. So then I began to look at my watch and I said, oh my gosh, I've gone past the 4-hour time. So the first challenge is making sure I keep track of the time. And it happens not just in golf, but I have to admit, in other things I get involved with, that's a challenge ongoing. For the last, go ahead.
And Dick, what has your physician done to try to give you more off time? Have your medications been changed?
Well, I started out with the last since 2012. I've had a dosage of 560 milligrams of Sentiment, and recently, well, not recently, but in last year, I went to 750 milligrams. So that was one way we were making adjustments to cope with that scenario. And then more recently, the 4 times a day, or the increase to going to 750, I've had experience of the Sonomet really not working for full 4 hours. Now I'm keeping track of it. I'm going with the 4 hours, but I'm still at about 3.5 hours, and I've tried to gauge the time so I can kind of determine what the situation is to get a firm read on it. And it turns out that it's now only lasting about 3.5 hours. So I've contacted my physician, and he's indicated that I can push the frequency to 3.5 to just basically take it when I need it.
And so it sounds like it's been really important to keep a kind of diary in a way of what's going on with your symptoms, so that you can report back to your neurologist what exactly is going on, and he or she can then adjust accordingly. Exactly.
They said that's been very helpful, and I've gone back and tried to be even more specific. In fact, this morning I tried to time it out. My basic scenario is that I take the first medication in the morning about 8:30 with about 16-ounce glass of water, and then I don't eat anything for an hour in order to let the medication have the fastest route to getting into my system. And then I punch the clock and time it out for 4 hours, and I'm reminded now I'm going to 3.5 hours, but that's just happened in the last week.
And so one of the things that's happened as you've increased medication, and your doctor's saying that you can take it when you to try to ward off those off cycles, so you can take it a little more frequently. I'm curious about whether or not by taking more of the drug, if you've begun to experience problems with dyskinesia, those uncontrollable movements. Has that been a problem for you at all?
Not yet. Again, the going to the 3.5 versus 4 is something I've just gone to in the last week or so. So the vote's still out, I guess, on that. But I've not had any negative impact for taking the 750 versus the 560. Basically, going from 3 to 4 times a day, essentially.
And I know you were a 17 handicap golfer. For those who aren't golfers, that means you're about a bogey golfer. You're about a 1 over par, which by my standards is very good. But that's gone up to being 6 or 7 strokes worse than that. And you have a specific goal, which I think is interesting, because you've had a very kind of determined plan about this and the way in which you're trying to live with Parkinson's. Can you describe what your goal is and how you're going about that?
Well, my 17 was probably 15 years ago, quite frankly, and it's morphed up into 23. And but I basically tried to re-engineer my swing to the point where I can number one, I can deal with the swing that I'm capable of doing based on my physical situation with the Parkinsons. But I also wanted to engineer a swing that would weather when the times come that will inevitably occur, where there'll be some tremorous impact or issues that I'll have to deal with out on the course, because it's not always going to be perfectly in sync and perfectly effective. So I've tried to develop a swing that I can lock down my arms and basically focus on my shoulders, providing the impetus for striking the ball, and be able to have some kind of a predictable result over time that will enable me to have some success at least. My goal, based on flashes of what I can see and what I've been able to do, I feel like I can lower my handicap before it goes back up inevitably, obviously, and I'm hopeful to get back down to 15 to 17 in the next 6 months or so. If that doesn't happen, it may not, but at least it's a goal that I think has some ability, some probability of being able to achieve it. We'll see.
And it sounds like, Dick, that that approach, having a goal, is really important in the way in which you manage living with Parkinson's overall. Could you just say a word more about that, about the importance you think it has to sort of really tackle these things and come up with a way of dealing with whatever it is that you care about the most, to make sure that you're still able to contend with that in a positive way?
Well, I think it started with the time when I was diagnosed, and I had the same experience that I've read others have had. When they get diagnosed initially, you have something that's incurable. You have something that is going to be progressive in terms of its impact on you over time. But then, as I sat back and realized that there are things that you can do to attack almost every element of what Parkinson's does to you, to either stave off the progression at least, or compensate in ways that will enable you to get things accomplished, albeit in a different way. And from the day I was diagnosed, I realized that, and as I read about what the impact was going to be, and realizing what the impact had already been here at the initial stage, that much of it boils down to making sure that gravity basically doesn't have its way with your body and with how you function day to day. You can think about it now, where you used to be automatic. The autonomic system would take care of a lot of this, but with certain training, and I've have undertaken physical therapy programs specific to increasing the volume on my speech. On developing a habit, which used to be automatic, but now a habit of picking up my feet, taking deeper breaths, making sure that I'm keep my mouth closed and sealed so that I don't drool at a time when I'd be embarrassed by it. All these things that people experience, but there are with conscious effort you can either overcome or compensate for much of this. So. I've just developed a mindset that I've had a lot of support around me to encourage me to do, and that's been a big part of it from my family and everybody that I know that knows I have this affliction. It's been very encouraging. Sorry.
Dick, stay with us. Just stand by as we continue our conversation. I think that's a really useful message. As I say, your swing looks good to me. Your left arm is straight. Your balance, I can see you're shifting onto your front foot as your backswing begins. So I think the prospects of getting to that 15 or 16 handicap, to me at least, look pretty good. So stay with us because we'll want to include you in our conversation as we proceed. But let me come back to our other guests who are joining us on our call today, and that is Dr. Lama Shaheen from the University of Pennsylvania and Dr. Todd Scherer, the CEO of the Michael J. Fox Foundation. Dr. Shaheen, Dr. Scherer, thanks both very much for being part of our conversation.
Thank you for including me.
And let's go through a little bit more of what Dick was reviewing for us and come back to this definition about on and off episodes. Dr. Shaheen, as you listen to Dick, I'm interested in your sense of how he's approaching this, both as far as dealing with the increased off times by really monitoring what's going on from his golf swing to other activities of daily living and reporting that back to his neurologist. Is that to you an important thing for patients to be able to do?
Absolutely. I think one of the most important ways to manage fluctuations is to first recognize them and to really be able to identify what periods of the day they're occurring, when it's predictable, when it's unpredictable. And, in some ways, Dick, because he has a tremor, is able to really identify the fluctuations very well. So he knows that, for example, a medication wears off at 3.5 hours because he starts to tremor. And it's really important to keep track of motor symptoms, but some people may also have non-motor fluctuations. For example, anxiety, palpitations, other symptoms. So it's very important to keep a diary. And the things that you'd want to think about is how long is it taking my medication to kick in? How long is it taking to wear off? And how do I know it's wearing off? What are the symptoms that are occurring? Also, is there variation throughout the day? So Dick mentioned, for example, that he times his meals according to his medication intake. That may be necessary in some cases. And also, Dave, as you mentioned, dyskinesias can become an issue. So really keeping a diary is the key to get the most out of the medication while minimizing dyskinesias and also helping us identify what other therapies may be necessary.
So let's look next at a little bit more about how we can get to the ways in which these take place. And one of the things that we want to talk about here is sorry, we're having a little bit of trouble again with the slides, but let me just move them forward once more. My computer's being a little balky. But we want to talk some about how these episodes are treated, and we've talked about different things that you can do to treat these, and including, as in Dick's case, increasing the different kinds of drugs that you can take. And again, Dr. Shaheen, this is where you can add additional Cinemet, but you can also, there are other drugs that you can add that may also help with the increasing the amount of on time that you have. Can you describe some of those, please?
Certainly. So it's important to go back to the reason fluctuations that occur. Fluctuations occur because the level of levodopa is fluctuating in the blood. It's really, or other Parkinson's medications, there's fluctuations in the amounts because until now we haven't been able to achieve continuous stimulation, though that, there's a lot of work on that we'll be hearing about. So if someone is, as Dick, for example, Dick had what's called wearing off at 3.5 hours. So as has been done, one of the simplest and often most effective strategies is to move the doses closer together. But there are other ways to extend the benefit from levodopa. So levodopa is a prodrug that's converted to dopamine in the brain and the rest of the body, and then it's broken down. So just as it's created by the body, it's also broken down by the body. And we're very fortunate to understand the metabolism of dopamine very well. And there are several enzymes that metabolize it or break it down. And we're very lucky to have medications that inhibit this breakdown or prevent dopamine from being broken down. Two examples of such medications. One are what's called the MAO inhibitors. They inhibit the enzyme called MAO. Rasagiline or Azalept is the one that is currently most commonly used. An older one that many people still may be prescribed, Selegiline, which is also known as Zydus, and a few other commercial names. The other MAO, the other enzyme that breaks down one of the other byproducts in dopamine metabolism are what's called COMT inhibitors. And an example of a COMT inhibitor is entacapone or Comtan. Comtan can also be compounded into one pill with Cinemet or levodopa, which is known as Stalevo. So they work at different enzymes. They have different benefits, different side effects, and different dosing frequencies, but the concept is these are medications to prevent breakdown of levodopa. I'm sorry, go ahead.
Well, but the challenge, of course, is that none of them have been surefire solutions, and we're going to get to in a moment, some of the new developments that are happening. But as a way of understanding why this has been a difficult problem to solve, even though there are these various possibilities right now that you were describing, I think it's also useful to just get a sense of sort of why these episodes happen. And so we've put up on the screen now a slide that Tasher, maybe you can help us understand a bit better about sort of why this difficulty happens and why it's a difficult problem to solve. Part of it, as we've already described, is the amount of time it takes for the drug to actually kick in. But part of it also is what's going on in the disease itself. You see in this second bullet point that early on you still have some dopamine functioning, but as time goes on, you have less ability to do that. And so that means even though you're taking the drug, it's not quite as effective because it's not being supplemented by what's still there. Is that right, Todd?
Yeah, so what's really happening, to follow up on what Dr. Shaheen was saying, is when we ingest the drug, there's a period of time when that drug is functioning in your body, in your bloodstream, and in your brain, but then the body also breaks down that drug. So there's this window where you're getting an amount of the drug into the brain that's effective, and it lasts a period of time until that amount of drug goes beyond that level, and that's when you then need to take another piece of the medication, another dose of the medication, and that sort of explains the peaks and valleys. Early in the disease, because of the way that the levodopa works, the levodopa is an ingredient that the brain uses to make dopamine. Early in the disease, in the brain, the cells have a lot of the other components and machinery that it utilizes to convert that ingredient of levodopa into dopamine. So you get a nice response that you can get from the dose of the medication because of how the brain processes it to make into dopamine. And you can get a larger amount of time where you're getting this good response to the medication. As the disease goes on and more changes happen into the brain is not as efficient in terms of converting the ingredient levodopa into the same amount of dopamine. And this is exactly what Dick was talking about, that over time he got 4 hours and now he's getting 3.5 out of that same response, the same medication. So what may have to happen then is either getting more of the ingredient, more of that levodopa in order to get a similar response as the disease is going on. One of the big challenges that comes on, and you see this in sort of the third slide, the third graph, is that that period of time can narrow and narrow as the disease goes on, so that the period of on time can be less. In order to try to maximize that period of on time, we may wind up giving larger and larger amounts of the dose of the drug, which then could put people in a position where they start to get some of the side effects of the medication to try to maximize the amount of time that you're on. So in that last slide, you see the period, the part that's colored in, that's sort of the ideal. In order to maximize that amount of ideal, you see how it's overshooting, and that's when side effects can come into play.
And one of the things then that's going on is that it seems like, Tasher, it's a bit of an obstacle course that the body faces with this. First, it takes a while for the drug to actually kick in because it's only the way in which it's metabolized. Then it has to work in concert with what you already have or no longer have in your brain. So it's not that the drug itself is no longer effective. It's just that the obstacle course that it has to climb over in order to be effective gets that much more demanding. Is that right?
Yeah, I think there's really two things that happen over time. One is, as you're describing, which is that the drug is being given in the context of a disease in an individual who's changing over time, so that that same particular dose of the drug may have a different effect because the brain has changed over the course of the disease. The other thing that does happen is that our brain changes just in response to being exposed to medication or to other environmental factors. The brain is a very plastic, what we call plastic organ. That's how we learn things, because we get exposed to a situation, the brain changes so that the next time we have that similar situation, we respond differently. So you have sort of those two processes happening simultaneously, where the substrate, the brain itself, is changing because of the disease, and the brain also changes because of the exposure to the drug. So that's what sort of changes over time in terms of how the individual can respond to that medication.
And I guess, Dr. Shaheen, the reason why I'm posing the question, to be clear about it, is that oftentimes people hesitate to start taking levodopa for fear that they won't have it when they really need it later on in the disease, and that there's sort of a fear of taking it too soon. But it doesn't sound like that's really the problem. There are a lot of other things going on, but that if you need levodopa to deal with the symptoms that you have, you shouldn't be afraid to take it. Is that right?
That's absolutely right. There's more and more information coming out, research coming out, suggesting that starting levodopa early is actually beneficial. One of the main reasons to try to delay levodopa when possible is that the sooner you start it, the more likely you are to get dyskinesias. That, in the greater scheme of things, when we're prioritizing what we're looking for in Parkinson's treatment, not necessarily a good reason to avoid taking it. So certainly if other therapies can be effective, they could be tried first, but levodopa is the oldest and one of the best drugs we have for Parkinson's, and there certainly should not be a fear. As used, it always continues to work, though then you run into complications, but it always, usually actually I should say, continues to work as it has in terms of benefit.
Let's look at some of the prospects for new therapies in development, and then we'll start taking all of your questions in just a couple of minutes. We've already reviewed the fact that to get more on time, you can either add the amount of Sinemet that you take, or you can add additional drugs, either ones that allow you to kind of hold on to more of the dopamine that you have existing in the brain, drugs such as rasagiline or others that block the metabolic processes that break down the drug, so you get more benefit from the drug. But there's some other new things coming up that we want to review in terms of how they may be of benefit in the future. So, TouchShare, there are a couple of different ways these can work. The first that we see on the slide are so-called rescue medications. Describe what they are. The first one, an inhaled form of levodopa that would work a bit like an asthma inhaler. What would that do, and how close are we having that to being on the market?
Yeah, so the general goal of all the therapies that we have listed here are to try to even out the day in terms of trying to avoid those peaks and valleys. So can we come up with improved ways to deliver levodopa or other dopamine-based drugs so that there's a more consistent exposure to the drug for a longer period of time? In the rescue therapy idea, what these really focus on are very rapid ways to get levodopa to the brain, or another, I'll talk about one in a second, that's another dopamine-related drug. So the idea is that as an individual starts to feel like they're going into their off period, so they're starting to enter a valley, or they're stuck in a valley, so frozen in a valley, can you have a therapy that gets levodopa or gets dopamine to the brain incredibly rapidly so that you don't have to wait for the next pill to kick in? And the idea is that this would really have the opportunity to even out the day and avoid getting into that nadir, the bottom of one of these valleys. So the levodopa inhaled form is in development now, where it has been developed, where you can deliver levodopa through an asthma basically type of inhaler, and it's been shown that through this mechanism, levodopa can get into the brain very rapidly, much faster than it can when you take it through a pill. When you take it through a pill, you have to swallow it, has to go through your digestive system, and there's only a very specific part of the digestive system through which the levodopa then gets into the blood. So that takes, a period of maybe, it could be up to a half hour to get that effect.
And then there are the other form of so-called rescue therapy is this thin film that would be right under the tongue of apomorphine, which is another one of the dopamine agonists, which would also similarly give you a quick hit, basically. Is that right, Todd?
Yeah, that's right. And apomorphine is a drug that mimics, it's a sort of a fake pretend dopamine in the brain. So it mimics the function of dopamine, or most of the functions of dopamine. Right now, the rescue therapy for apomorphine involves an injection. And this particular approach is to try to convert that, if you are familiar with the Listerine strips that you just place on your tongue, to deliver apomorphine using that mechanism, again, to get it very rapidly into the brain in a way that's not highly invasive. And, for example, it doesn't involve a shot. And again, the idea is to get that really rapid onset of an effect to give a window now before the next medication kicks in.
And both of these are currently in late-stage clinical trial. The next things that we're going to talk about in intestinal gel is actually something that's already available in Europe and also in Canada, and is currently under FDA review in this country. How does that work, Todd?
Yeah, so this one is definitely a more invasive approach in that it involves a surgery. But as I was describing before, one of the real challenges we have with levodopa is that there is really only a very particular part of the digestive system through which levodopa gains access into the bloodstream, and then from the blood is how it gets into the brain. So when you take a pill of levodopa, actually a lot of that medication is lost through the digestive system before it gets to the part of the digestive system where it can then get into the bloodstream. What this approach looks to do is actually, using a surgery, is to directly infuse the levodopa into the part of the digestive system where it gains the access to the blood. So you can really get a continuous exposure to levodopa into the bloodstream and get that continuous delivery into the brain.
And that is currently under FDA review, as is the next thing that we're going to look at, which is an extended release pill. That's also something that could be on the market relatively soon.
Yeah, that's right. And there have been a lot of attempts to do this, which is to just figure out ways through the packaging of the medication, of the pill, to have it have a longer effect or stay in the digestive system a little bit longer, or get more to the region of the digestive system where we get that exposure to the blood. This is one that there's a recent one that's under development that's about to go for the FDA approval. And this one particularly can give some increase in on time or reducing off time.
Let's start in with all of your questions. Lots of questions coming through. We'll come back and talk further about some of these new therapies in development. But if you have a question for Dr. Shaheen, Dr. Scherer, or for Dick Fitzgerald, do fill them out, and we'll spend the remainder of our time taking as many of your questions as we can. This one first comes from Mark, which is, how close are we to the inhaled levodopa therapy being available at the pharmacy? It's in late-stage clinical trials. Todd, what typically might that mean? If it goes forward and everything goes well, it gets to the FDA, what are we talking about in terms of when that might be on the market?
Yeah, I think we're still talking about, for this one, a couple of years away. They are doing their late, what we call a phase 3 trial, so sort of their late stage trial. So they still have some work to do, but it is, this would be probably the last phase of testing that they have to do.
Another participant question, Dr. Shaheen, which I think is a really interesting one, is are off episodes worse than just the normal tremor that you might have, before you take your medication? In other words, is an untreated tremor different than an off tremor?
That is a good question. I think, that it depends on various factors. For example, what time the prior dose was taken. So in most people, they don't go entirely off. So what I would consider to be entirely off is 12 hours off all medications. So that would, for example, be when your tremor would be worst. During an off episode over the day where you've taken some medications and hopefully they haven't entirely worn off, and most people, their tremor is not as bad as it would be entirely off, medications for several hours.
Another question here, are there warning signs? Can you tell when you're about to go off? Dick Fitzgerald, why don't you respond to that first, and then Dr. Shaheen, you chime in. But Dick, can you tell? Do you have kind of an early warning device that lets you know that you're about to start having some real problems?
It varies. I guess more often than not, when I'm beginning to not have the benefit of the medication, I feel a little bit of I don't know if it's anxiety or some slight level of trepidation. Then it goes from there into a progressive tremors feeling and occurrence with my left hand. So there is a progression to it for me.
And Dr. Shaheen, is that what you hear as well? And is that where some of these so-called rescue therapies, whether it's the apomorphine that dissolves on the tongue or the inhaler, might be particularly useful when you sort of feel like something's coming on?
Certainly. So there are, I think we could talk about two types of off episodes, predictable and unpredictable. And predictable ones, you kind of know when it's about to start, and there's certain symptoms such as what Dick suggested, anxiety, which suggests that it's about to start. If they're predictable, then you'd want to reschedule the way you're taking your Cinemat or add on some drugs. But if it's unpredictable or you're in a situation where you need rescue, you can't wait for your medication to work, or the off period has come on suddenly without warning, that is certainly a great time to take those medications. So right now we have an injectable form of apomorphine, but those inhaled or under the tongue formulations would certainly be a great plus to have.
And a touch here, Dick Fitzgerald began his answer by saying it varies, and sometimes I think that's sort of the answer we all feel about living with Parkinson's. It varies. It depends. It's not, by definition, it's not a very predictable experience.
Yeah, I mean, it varies across individuals with the disease, and then it varies day to day within an individual. And I think that is, one of the biggest challenges of living with the disease, and one of the big goals of having better delivery of these therapies that can be more consistent and not rely on so many variables such as when you ate, how your digestive system's working, other aspects that are happening that day, would be a huge benefit if we can come up with a way to crack that.
I would also make...
Yeah, go ahead, Dick.
Just one other comment. A lot of what I experience on the tremors and so forth, even though I've taken medication on time and that while I'm playing golf, it's effective for that activity. If I'm taking the medication on schedule and I'm not having a problem, but if I engage in certain kinds of activity, it will transcend the benefits of the medication at that point in time. If I do a workout where I'm doing some extreme, lifting weights and that sort of thing, it'll surface despite the medication. So it depends on the activities at the time. for me.
Yeah, that's a useful point. Here's another key question, I think, Dr. Shaheen, from Carly, who writes in, how do you avoid being over-medicated if you take one of these, like the quick-dissolving apomorphine, or when it comes on the market, the inhaler? Would that be a concern, that you could sort of overdose on the amount that you're taking?
Certainly. I think the key with all these medications, especially when a new medication is being introduced, is to start at a low dose that may not necessarily be effective, but then increase the dose slowly, or what we call titrate it, to reach benefit while minimizing side effects. Everyone is different. Every body is different. So there's certainly not like one dose that one should be at. And so starting low and going slow, titrating the dose is essential to finding a dose that's beneficial without creating major side effects.
A couple of people are asking about stress. Dick Fitzgerald mentioned earlier that one of the symptoms he can feel as he's going off is a sense of feeling somewhat anxious. And Cynthia raises the question, Dr. Shaheen, of whether or not stress can shorten the efficacy of levodopa. So can you say something more about whether or not feeling anxiety is a signal for being off, but also, I guess, along with that, whether or not stress and anxiety can limit the effectiveness of the drug too?
So I think, Dick gave a great example where, if he's doing sort of routine daily activities, his symptoms are fairly well controlled on a given dose while it's working. But then if he exercises, that kind of transcends, is the term he used, the benefit. So certainly there is, things like excitement, bad or good sort of excitement or stress can make many Parkinson's symptoms worse, including but not limited to tremor. And anxiety can also be a symptom of wearing off. So both of those are absolutely correct. And it's important to recognize the difference between them. So if anxiety is occurring mainly as a wearing off phenomenon, that suggests that either medication timing needs to be changed or dopaminergic meds need to be added. But if the anxiety is there's a lot of stressors, or there's an anxiety disorder that's separate, that would be treated differently. So it's very important to think about those different aspects.
And another way also, I think, of reminding us of Dick's earlier point about the importance of keeping it almost sounds like a kind of diary of what's going on with your symptoms, so that you're able to pinpoint not only the experience that you're having, let's say stress and anxiety, but whether that's connected to a feeling of being off, or whether that's connected to some other aspect of your life. Because you as a neurologist, I would think, Dr. Shaheen, that information and the timing of when those experiences take place is really crucial for you to be able to then respond in the best way.
Absolutely. The motor diaries are essential and really very helpful. And sometimes people will say, I really can't find a pattern, but when you start keeping at times an hourly record of what's going on over a few days, a pattern is revealed. And there are standardized motor diaries. They can be found online. You could ask your neurologist for one and just keep it for 1 to 2 weeks and see what patterns emerge.
Todd, we're getting a lot of questions about the impact of both food and alcohol on the way in which these medications work. So why don't you give us a little Digestion 101 here about the way in which levodopa works, and whether or not both food and alcohol are a problem in terms of making sure that the drug you take makes its way to the brain.
Yeah, I think that particularly as it relates to food, there are some aspects of food, like proteins, that could potentially interfere with the body's ability to get the levodopa into the blood. Levodopa is obviously normally a natural product. I mean, our bodies make its own levodopa. So that's something to be really cognizant of, and like Dr. Shaheen was saying, these are things that you could pick up as you keep track of things to see, is there some relation to certain things I've eaten and how I'm responding to the medication. I think, obviously with alcohol, you always want to be careful with the use of alcohol, and as it can impact balance and things like that. there are some potential benefits of red wine and things like that as well. But I think these are particularly around diet, things just that, everyone's a little different. The most thing we know is about some of the protein and how protein can interfere with some of the medication, particularly levodopa's absorption into the body. But I think keeping track of things like this could be really helpful.
But it sounds like, Todd, there aren't specific, and Dr. Shaheen, chime in on this too if you have an observation, there aren't specific prohibitions to if you're taking levodopa, carbidopa, or any of the other standard Parkinsonian drugs to not have that glass of red wine. Is that right? We're okay to do that?
Yes, I think that the concern with alcohol intake and medications in general is the additive effect on sedation. So if you're on Parkinson's medications that make you sleepy, you don't want to add on to that by drinking alcohol, but certainly a glass of wine, if you tolerate it, you don't get too sleepy, it doesn't, as Todd mentioned, affect your balance. It's definitely not something you should deprive yourself of, and could potentially be beneficial, as Todd mentioned as well.
A question from Kieran on whether or not cognitive symptoms can be connected to the off cycle. We all worry about cognition as a problem later on in Parkinson's disease. But Dr. Shaheen, are there any? We've talked about physical symptoms worsening, anxiety, emotional symptoms worsening when you're off. Can cognition also worsen?
Yes, I've heard several individuals with Parkinson's describe a sensation of feeling foggy, not being able to focus as they wear off. So that certainly, it is usually reversible in the sense that, like other off symptoms, it's medication responsive, but fogginess, inability to concentrate, not so much, for example, memory loss, but just sort of inability to, inattentiveness and other similar symptoms.
Dick Fitzgerald, can you comment at all on that for you? Do you have a sense when you're off of being not only not quite as sharp physically, but a little bit less sharp also cognitively?
I'm let me make sure I was off of mute. That really hasn't been a focus for me. I've been so focused on the physical aspect, I haven't noticed enough difference to think that that's been a significant issue. Having said that, I felt like I had some recall issues, and this may or may not be related to the Parkinson's, but my doctor had prescribed for that Dipazole. Not sure I pronounced it properly, but basically just for memory, not just for that aspect. And I think that has been helpful. But generally, I'm not sure how that plays into your question, but that's as much as
yeah. Well, and as always, it's so hard to sort out sometimes which of these things are connected to the disease, which of these connected are to aging. You and I, Dick, are about the same age. Which of these are connected to off effects? It is hard to sort of pinpoint which is what, and again, probably points to both the point you and Dr. Shaheen have made about doing a good job of keeping track of these things in some sort of diary. Meredith asked the question, do these rescue therapies have the same side effects as higher dosages of levodopa? So in other words, Todd, although we don't have things like the inhaler yet, would taking the inhaler pose problems for having greater dyskinesias?
These are all possible because the medications, these are just different delivery mechanisms of the same medication. So there's nothing really, for example, in the inhaled form of levodopa, there's nothing different about the levodopa and how it'll impact the function of the brain. So it's the one side of it is these will be able to treat the same symptoms that respond to the regular oral levodopa, Sinemet that is taken, and has the same potential benefits and same potential side effects. And it's really about trying to get the maximum amount of time during the day when you're in that sweet spot where you're getting the benefit of the medicine without dipping into any of the side effects.
Question from Daria, Dr. Shaheen. What symptoms suggest it's time to begin levodopa? How do you know you've reached a point where levodopa is called for? And this is the classic question, of course, that every Parkinson's patient contends with. We talked a little bit earlier about that you shouldn't be afraid to take it for fear of it sort of exhausting itself too soon. But how do you respond to that very basic question about when is it time to start taking levodopa, carbidopa?
You know, the decision to start levodopa, in my opinion, should be largely based on how the Parkinson's symptoms are impacting the individual's daily activities and quality of life. So some people, don't feel bothered by a tremor. It doesn't bother them in any way. They're able to otherwise do all the activities they want to. And some people, if they have a very mild tremor, are very much bothered by it. So if we just go by how much it is a bother to the patient, both in terms of their ability to function and their ability to perform their daily activities, is really, and to, as you mentioned, have a low threshold, so not wait until really we're really uncomfortable or can't move or not being able to function to start it. But everyone's threshold is different. But those are the two things that, in my opinion, should guide it: activities of daily living and quality of life.
And Dick, I know you've said that as well, that you think the key question that you should always talk about with your neurologist, or that you talk about, is this question of, well, am I able to do what I need to do? And that's always what you need to come back to, and that's what governs the right kind of medication to take.
I've been reading. I'd read that the declining effectiveness of the drug over time, and so I've developed this sensitivity because of that to taking any more than absolutely necessary. And my doctor's response was, well, that may be the case, but you're at your age, you're able to do things that you won't be able to do when you're 80. And so the time to get the benefit from the levodopa and the medications that are available now is when you can be the most active and benefit from the benefits that are provided. And so even if that is the other is the case, you use it when you need it. You're younger now, and you'll be able to benefit more from the meds.
Right, and keep working towards getting back to that 15 handicap. Brett asked the question, Dr. Shaheen, does strenuous exercise involving a lot of movement decrease or increase wearing off times?
I think that, certainly stress. I'm sorry, can you repeat the question, Dave? I think I might have lost you briefly.
The question is whether or not strenuous forms of exercise increase off time. Yeah. So does strenuous exercise, I guess, diminish the effectiveness of levodopa?
I would say in general no, but as Dick mentioned, if levodopa is providing a certain benefit, and then you participate in strenuous activity that could, for example, increase a tremor, that wouldn't necessarily be off in the sense that the levodopa is wearing off, but that it's not being able to suppress the tremor during that period of increased excitement. But in general, exercise, we don't have a lot of data on this, but there's some suggestion that exercise actually helps motor control and can be very beneficial. We don't have a lot of data on motor fluctuations, but hopefully we will soon.
And a question from Meredith. Yes, go ahead, Dick.
Well, no, I was just going to say that I do a personal training session 3 days a week, and some of it involves lifting weights and such. And I think, as I indicated, during times when I'm really stressing, particularly my right side, the left side will kick in. But I would say that once the session is over and I've recovered from the workout, I then resume the benefits of the medication if it's not long lasting.
A question from Meredith Toucher about DBS. Meredith writes, is it true that off time would be diminished by DBS? We haven't talked about deep brain stimulation, but it, of course, is something that can be very effective for minimizing certain symptoms of the disease, tremor perhaps in particular. So in some ways, is DBS, deep brain stimulation, a kind of solution for the off-time problem?
Yeah, I'll start to answer, and it's probably helpful for Dr. Shaheen to jump in. Deep brain stimulation can be very effective at treating the same symptoms or many of the same symptoms that respond to levodopa and can particularly be helpful for people that have a good response to levodopa but do have a lot of the fluctuations during the course of the day. So they still respond to the medicine, but it's requiring a higher dose, and they're getting a lot of these on-offs, shorter ons and more offs, or even some of the side effects from the ons during the course of the day. But I think it'd be helpful for Dr. Shaheen to comment as well in terms of thinking about what types of patients would be, most likely to benefit from deep brain stimulation.
Yeah, so I definitely agree with Todd that DBS can be an excellent treatment for motor fluctuations. As Todd mentioned, the key is to select the appropriate candidate for deep brain stimulation surgery. So what is a good candidate? It is someone who responds to levodopa and that the symptoms that bother them the most are levodopa responsive. So expectations become very important. What is the goal of doing DBS surgery? It can also help with dyskinesias. If someone has cognitive problems, dementia, or symptoms that are not responsive to levodopa, for example, gait problems, freezing that doesn't respond, these people are less likely to benefit from the surgery. There's also a relative age cutoff that not a cutoff, but we do look at age of the individual when we're deciding about DBS as well. But what's two exciting things that one, DBS itself is being further developed, and we're hoping to eventually have what's called responsive stimulation, where the device actually responds to how the brain cells or the dopaminergic cells and other brain cells are working, so that sort of the device would eventually, hopefully, respond to situations. But the other exciting thing is some of the intestinal infusions are going to be very useful for people who are not DBS candidates. So we're now hopefully going to have two surgical options for Parkinson's disease soon.
A couple of questions about whether there's any difference, Dr. Shaheen, between the generic form of carbidopa-levodopa and Sinemet in terms of either their effectiveness or off-cycle. Are there differences in the variety of these drugs?
The short answer is yes, but most of the formulations of generic Sinemet are, we think, very good quality. Most people, obviously it's much cheaper, and the brand name is not even be available in some places. So in the majority of cases, we try the generic form. There are some people allergic to certain dyes in the generic form, or who were switched from the brand to the generic and felt they did worse. And in those people, certainly the brand name would be indicated. But we're very fortunate that the Parkinson's generic drugs are generally, we think, very good quality.
Question from Susan. Todd, with no changes in medication or in the timing when medication is taken, what would cause the off cycles to last longer? Is that something that likely goes back to what you were saying before about just the progression of the disease, that's part of what is going on? It's not just when you take it or whether or not you've had a meal. Some of what's interacting is also just how the disease has progressed.
Yeah, I think there's really two. Well, there's a lot of factors that could influence this, particular situation. One is exactly what you said. The brain is changing over time because of the disease. So if you give the same amount of medicine to that, in year 1 versus year 10, it's a different brain. The brain has changed. The brain changes because of the disease. It also changes in response to the medication. So I think that both of those are important aspects. But there's also a lot of things that can impact how your body responds to a medication, the things that you eat along with it, other drugs that you might be taking. So I think there's a lot of factors that are involved, which is one of the real challenges of why this can be so variable day to day for individuals.
And Todd, just a last question as we come to the end of our webinar. It's obviously been a long road and continues to be a long road to find a way to modify the progression of the disease and, of course, ideally at some point be able to cure the disease entirely. But at the same time, there's this question of how do we deal with the disease here and now, right now. And this feels like an area in which progress actually is being made, that we are closer to figuring out a way to contend with the on-off cycle and get people ways of contending with that relatively soon. Do you agree with that? Is this an area of optimism for you?
Yeah, I mean, I'm optimistic about everything you just said, but I think this is an area that, the levodopa we know works. We've known that for a long time. But there have been some major advancements in a lot of these drug delivery technologies over the last, 10 years, 10 to 15 years, that we are now really seeing the fruits of those being applied to levodopa. And we know if we can just figure out better ways to get it to the brain faster, we know what it's going to do in the brain. So I am optimistic that we're making a lot of progress. We still have some work to do, but I think this is a very promising area that could have, a huge benefit in the relatively short term.
With that, we must bring our webinar to a close. I want to thank Todd Scherer, along with Dr. Lama Shaheen and Dick Fitzgerald, for their participation in our discussion. You can watch previous webinars by going to our website, michaeljfox.org/webinars. We also want to remind you that one of the keys to advancing the goals that Todd just described, and our, of course, overall goal of finding a cure for Parkinson's, is to participate in research. And you can find out about what research projects are near you and match you if you go to foxtrialfinder.org. So thanks all very much for joining us for this webinar. We will be back again the third Thursday in July, when we will take up the topic of sleep in Parkinson's disease. Thanks, everyone. I'm Dave Iverson.